All right, everyone. Thanks for joining in for this short video. For those of you that don't know me, my name is Stephen Peach. I'm a physiotherapist and a clinic owner at Peach Physiotherapy. Something we see a ton of in the clinic is osteoarthritis, particularly for the knees and hips. A lot of people come in and they say that their doctors told them that they have arthritis, and they really don't know what exactly that is. Now, there are several forms of arthritis, but today we're going to be talking about osteoarthritis specifically, and that's something that affects a ton of people, and it is super, super common. So we'll kind of jump right into things and try to keep this video nice and short. So a little bit about me. So I was born and raised here in Chatham. I graduated from University of Windsor with a human kinetics degree in 2010, and then went on to do my master's of physical therapy at Western and graduated in 2012. So in 2014, I opened the clinic, and it's been an amazing ride ever since. So there's a lot of areas that I really love about physio. I've done some continuing education about osteoarthritis, about running injuries, manual therapy or hands-on treatment, things like acupuncture and dry needling, spinal manipulation, concussions and vestibular rehab, just to name a few. So you see my two little monkeys in the picture. That's my daughter Isla and my son Brooks on Isla's first day back to school this year. So Brooks loves that toy steel leaf blower, so he won't put it down a lot of days. Now, today we're going to chat about what exactly osteoarthritis is and how it is diagnosed. Now, most of the time, it's best to start about talking about what the healthy joint looks like, and specifically the healthy knee and hip. So to get to that point, I want to pull up another program that you guys should see here. And now we're looking at a skeleton. So when we're talking about osteoarthritis, let's start at the hip. Now there's some major structures that we should get to first of all. And we're going to start off by looking at some connective tissue. So we're going to start adding layers around the joint. You can see this kind of capsule or this green portion around the joint. And what that is it's the joint capsule or the synovial membrane. And what that membrane and that connective tissue around the joint does, it provides some stability, it traps everything in, but it also creates what's called synovial fluid, which is a natural lubricant and what nourishes the joint. Okay, so if we keep adding more layers here, we start to see a little bit more of that joint capsule. So then we start getting into that thick, fibrous connective tissue around the joint, almost thinking of like shrink wrap around the joint. We start adding in ligaments, where we start seeing some of them around the hip as well. We can start getting into things like, more ligaments there. We're going to get into some of the bursas. Hip bursitis is something that people come in with that diagnosis often. And let's see, and I think we get into that final layer of the skin, which is actually considered connective tissue. Now, if we strip all those layers down and give it a second here, we get back to just the joint. And this area that's going to pop up green here in a second, that's called the articular cartilage. Okay, now articular cartilage lines both sides of the joint, and we can get osteoarthritis in any joint that has articular cartilage. Think of it as a sponge. Okay, the inside of the joint doesn't get good blood supply, so we rely on that synovial fluid in order to provide nourishment. So without blood supply, without a heartbeat pumping blood and nutrients to the structures, we rely on a loading and unloading of the articular cartilage in order for it to push out old synovial fluid, and then as it recoils, it sucks fresh stuff in. So the articular cartilage functions almost like a sponge to stay healthy. Okay, now we can get into adding several layers of muscle all around the joint that provides dynamic stability and strength of the joint as well. So this program is kind of big and bulky, so it's just moving slowly. But there are lots and lots of layers of muscle. And we'll start taking those away, and we'll go down a little bit further down the leg and start looking at the knee. Now, there's one major difference between the hip and the knee, and that is the presence of meniscus, okay? So the knee has something called a meniscus, which is going to pop up here in a second. There we go. So if we start looking in close, we have a medial or a middle meniscus, and then a lateral meniscus. And the meniscus is kind of like a shock absorber for the joint, okay? With the knee, if we take that away, we can see that the joint doesn't actually fit together super well. So we rely on that meniscus to make the joint more congruent and, like I said, act as a shock absorber, all right? Now, just like the hip, we also have our cartilage. We can start adding in several layers of connective tissue. So we'll start having this pop in, hopefully. There's back the meniscus back. Start getting into that synovial lining, this capsule. We have a fat pad there, which is in the yellowy orange, into the bursas. We start seeing more ligaments across the knee, and there we should have the skin again. And then of course we also have lots and lots of muscles that support the joint as well. So big difference between the knee and the hip is the knee has a meniscus and the hip does not. The hip has a labrum, which is somewhat similar, but it's definitely a little bit different than the meniscus, okay? All right, so let's keep going here. So getting back to that articular cartilage, like I said, it doesn't have nerve supply or blood supply. And the big thing without nerve supply is literally it's as simple as no sense, no feeling. Without nerve supply, we really can't have pain coming from those structures, okay? So it's not the cartilage itself that causes an issue or causes pain with osteoarthritis. It's the structures around the joint, like the capsule, like the ligaments. It can also be the bone underneath the cartilage. All right. If you've had an x-ray, just like we see on the screen here, that shows that you've lost all the joint space within the joint, you may have been told that you're bone on bone. And what that means is that all the cartilage has disappeared and the bone underneath the cartilage is now getting loaded. It's thicker, it's stronger, and that can certainly be a cause or a source of pain. Okay, so articular cartilage relies on synovial fluid. It acts as a sponge, okay, for loading and unloading, pushing nutrients out when you load it. And then as we unload it, it sucks fresh stuff in. And we rely on that regular loading and unloading to keep the joint very healthy and stable. Okay, now some of the changes that we see with osteoarthritis, okay, believe it or not, osteoarthritis is more common than blood pressure and diabetes, okay? It's super common across the population. It's the most common lifestyle disease in people over 65. So it's the most common condition that affects and changes people's lifestyles, whether that means not participating in sports or activities the way they used to. They're finding certain things difficult to do because of the disease. It's the most common in people over lifestyle disease in people over 65, okay? 30% of people over 50 years old will report hip and or knee pain. Now, of course, that doesn't necessarily mean that everybody has osteoarthritis over, or 30% of people have osteoarthritis over 50 that's causing pain, but it gives you an idea of how prevalent hip and knee pain can be, okay? One important thing too is that the disease does affect the whole joint. It does not just affect the articular cartilage. The bone underneath of the articular cartilage is affected. The muscles are affected. The connective tissue or ligaments and capsules around the joint are affected. So it affects everything, not just the articular cartilage. we used to hear osteoarthritis described from physios, chiropractors, doctors as wear and tear. And the reason why we try to get away from that language is because our bodies need the right amount of exercise and load in order to stay healthy. Our joints aren't like the tires on our cars. We don't get a set number of kilometers to use them, then they need to be replaced. Okay. Think of it as like a vehicle. If you left your vehicle in the driveway and didn't drive it for 5 years, when you go to start it, it's probably going to be in pretty rough shape. If you didn't take it off the road for 5 years and you drove and drove and drove every single day, it's probably also going to be in rough shape. But if you drive lots and you take care of your vehicle, just like you take care of your joints, you'll be absolutely fine. Okay. Now, the most commonly affected joints that we see, as I mentioned, definitely the hips and the knees, and actually more common than the hips and the knees are your hands, and specifically at the base of your thumb and the knuckles in the fingers, okay? Now, of course, nobody's told me about a finger or a hand replacement yet, but we have talked about hips and knee replacements, so they definitely get more of the publicity. All right. All right. Now, there are definite things that can contribute to osteoarthritis. Now, the first thing I want to talk about is injury. Okay. Now, if you've had a significant joint injury, for example, a major ligament tear, so you've torn your ACL, or maybe you fractured a bone very close to a joint, so let's say you fractured your ankle, you are more likely to develop osteoarthritis in that joint. And that may be because of some mechanical changes that have happened, the joint's moving slightly different than it did before. Can also be because we've caused a bit of an inflammatory response, and now there's different chemical processes happening in the joint that otherwise wouldn't be happening. Okay, so injury is one of the major things that can contribute to osteoarthritis. Now, next thing I want to talk about is persistent load. And coming back to that wear and tear idea, there aren't many things that are actually associated with increased prevalence of osteoarthritis. And you see the picture of the farmer there. Now, one thing that we do see, or there is an association between, is male farmers have a higher prevalence of hip osteoarthritis. Okay. Now, another profession that we see an increased likelihood of osteoarthritis in are miners, which we don't see a lot of in Chatham-Kent, of course, or any for that matter. All right. Now, marathon runners, recreational sport players, these aren't really enough to be considered persistent load. And really, there's no link between those activities and osteoarthritis. If anything, activities like running and moderate activity and moderate exercise have a protective effect on our articular cartilage and our joints. Now, there are people, of course, that normal load for a vulnerable joint can cause some osteoarthritis, okay? If you have a parent that has had a joint replacement, that's not the result of having a bad injury in previous years, you are more likely to develop osteoarthritis and possibly need a joint replacement, okay? So there's definitely a genetic component to osteoarthritis that unfortunately we can't change, all right? However, you can be genetically predisposed to osteoarthritis, but if you do all the right things through your life, you can manage and do very, very well and never need surgery, okay? All right. Now, symptoms of osteoarthritis. For anybody out there that has osteoarthritis in their hips or their knees, this is going to sound like a grocery list that you are very familiar with, okay? With osteo, symptoms can develop slowly over many years, but they can also happen very suddenly. And that's something that pops up in the clinic often. People will come in, they very clearly have osteoarthritis in their knee, and they say, it just started out of the blue one day. And they say, how can it be osteoarthritis? It just started out of the blue. That does happen. I don't have a good explanation for why the symptoms start suddenly, whether you've done something different or something with your body has changed and it's just been the straw that broke the camel's back and pushed you to the point of pain. Osteoarthritis or symptoms of osteoarthritis can start at the drop of a hat or take a long time to develop, okay? Early in the process of osteoarthritis, symptoms or pain usually only happen when you're weight bearing, when you're up and moving around. That doesn't mean that you shouldn't weight bear. In fact, exercise and weight bearing is very important in management. But early in the process, we usually only get pain when we're weight bearing. Okay. Oftentimes people will report that, they have what's called crepitus, or their joints are very noisy and make crunchy grinding noises. That is a symptom, but we know that that noisiness is completely harmless. It doesn't tell us anything good. It doesn't tell us anything bad. It's just, it is what it is, okay? But it's not an indication that you're wearing your joint out or something's rubbing and wearing down every time that you move. Now, stiffness and reduced range of motion is another symptom. For somebody with hip osteoarthritis, they might say, now I can't get down to put my socks on in the morning, or I have a hard time lifting my leg in and out of the car, all right? Feelings of instability are also common. Now that might be because it's painful. It can also be because we've physically lost some of the joint space within your hip or the knee, which creates a little bit of extra wiggle in the surrounding ligaments and soft tissues. Okay, so we will see that in some patients. All right. Now, later in the osteoarthritis process, some people can start to experience pain at rest and pain at night. And that usually means that it's more of an inflammatory issue. So pain at rest and pain at night often will mean inflammation. All right. Now, pain location can vary big time with hip and knee osteoarthritis. People with hip osteoarthritis will most often report pain on the outside of their hip and at their groin and down the front of the thigh. But people can also have lower back pain. They can also have pain at the back of the hip. They're all common areas of pain reports. Now with the knee, again, pain will vary considerably. Oftentimes people have pain on the inside of the knee, but pain can be at the front of the knee, the side of the knee, at the back. Sometimes it can even radiate down the shin as well, okay? And ultimately, people with osteoarthritis will report difficulty doing stairs, difficulty squatting, difficulty kneeling, difficulty lifting heavy things or any quick directional movements, okay? It's very, very common. All right, now we're getting into the nitty gritty on how things are diagnosed. Now, if I ask you that right off the bat, most people will actually tell me that it's probably diagnosed with X-ray. And I'm going to tell you that that's not the way that it's diagnosed. Diagnosis should be made on the patient's symptoms and a clinical examination and the presence of risk factors. So for example, if you're a 67-year-old farmer with hip pain and you have limited range of motion and pain weight bearing, it's safe to make the diagnosis of osteoarthritis, okay? Now, imaging, X-rays are the most effective means to detect osteoarthritis on imaging. X-rays are actually more effective than MRI, particularly weight-bearing X-rays, but we don't need those to make a diagnosis, okay? It's based on what the patient reports and what they feel, and then also their subjective history and their presence of risk factors, okay? Believe it or not, changes on X-ray actually happen later in the disease process. So people can have a very clear diagnosis of hip or knee osteoarthritis for 10 to 15 years before we actually see significant changes on X-ray, okay? Which tells us that we really, even an X-ray isn't a great means to say what's going on. Now, if it's later in the disease process, an X-ray might tell us that if somebody is appropriate for a knee or a hip replacement, but it's not needed for the initial diagnosis, okay? Another side of the coin with x-rays is that there's a stronger correlation and association between muscle strength and pain than there is between x-ray findings and pain. So there's lots of people out there with very osteoarthritic x-rays with very little pain. And there's also people out there with very clean x-rays or very little change on their x-rays and lots of pain, okay? So the picture doesn't tell the entire story, okay? So, all right. So that's a wrap for everything in this video. If you guys want to find out more about managing osteoarthritis, please send me an email, let me know, and I can make another video. I will give you a hint what's more effective in managing osteoarthritis, pain, and overall function. Isn't medication, it isn't injections, it's exercise, okay? But of course, you need somebody to tell you to do the right exercises at the right time based on your needs, okay? So thanks everybody for watching this video, and yeah, send me a message if you guys have any questions. Thanks, bye.